This is for those who believe in the potential of science, making brave choices, choosing to push the boundaries. This is why we believe in what science can do.
It's really a great pleasure to be here with you this afternoon to talk a bit about one of the aspects of science, namely the biological sciences as it relates to medicine. And I thought I would do that in the venue of talking to you a little bit about my career in infectious diseases and point out some of the issues that you yourselves may face as you pursue or not a career in science. And I've entitled it From HIV to Ebola. So I often get asked by young people like yourselves, how did I happen to get into the field I got into? And it isn't something that you know right from the beginning, and you're going to see that in your own career, but I'll tell you a little bit about mine. I was born in New York City in Brooklyn. I went to a school, a Jesuit high school. This is my father in front of his pharmacy in Brooklyn, which people say, is that the reason why you went into medicine? I'm not so sure that's the reason, because at that time, I wasn't really sure what I wanted to do. But I went to a school that was very heavily steeped in the classics. And the reason I tell you that is that when I first started off on a career in academia, I actually did not know that I wanted to be in science. I actually was more interested in sports and the humanities that I were. I played basketball, that's me, number 4. Found out very quickly that a 5'7" point guard will never make it in the NBA, so I decided that maybe I rule that one out for my career. Went on to college at a liberal arts college, and again, I'm telling you this because it wasn't like I jumped out of my crib as a child deciding that I wanted to be a scientist at all. I had a somewhat circuitous route where I had more courses in Greek, Latin, French, and other Romance languages, translating the Iliad and the Odyssey, until finally I decided I wanted to combine the humanities with science because I was very attracted to the discovery of science. And so what I did is I went to medical school in New York City, and that's a picture of me as an intern in medicine. I decided right off that I wanted to go into infectious diseases, and I came to the National Institutes of Health right here in Bethesda, just a few miles north of where we are right now, in the Institute of Infectious Diseases. And I had an experience that I think is important for me to point out to you, why it's important when you're in a career, particularly in science, to have a mentor that you could relate to and that could help guide you. I was very fortunate. I happened to have a mentor shown on the right-hand side who took an interest in me and nurtured my dual desire of wanting to be a basic scientist at the same time that I wanted to have a close interaction with people. And I wanted something that was very exciting and acute and that you could do something about. And that's the reason why I went into infectious diseases. Now, I did that for about 9 years until something happened to change my entire professional direction as well as my life. And I tell you this only to point out that you will be faced by surprises and unexpected things. So one of my mottos that I tell young people is always expect the unexpected, because I was heading towards a career in classic infectious disease, and then this particular publication landed on my desk in June of 1981. And it was 5 young men, all gay men from Los Angeles, who presented with a strange infection that you don't see in people except those who have a very compromised immune system. I thought it was a fluke until a month later, another publication came out, now of 26 people, again, all gay men, now from Los Angeles, San Francisco, and New York. This was the beginning of the AIDS pandemic. And I decided at that point, since I was an infectious disease person, intensely interested in the humanities, and this was an extraordinarily devastating disease with no known cause that I devoted my career from that time on to HIV/AIDS. And this is a picture of me in the early 1980s at the bedside of an AIDS patient. Now, I show it to you because at that time, before we even knew what the virus was, or even if it was a virus, the median survival of my patients was 6 to 8 months, which means that 50% of them would be dead in 6 to 8 months. That is a very difficult thing to go through. I consider it the darkest period of my professional and personal life because I had to deal with every single day, every one of my patients dying. But here's where the beauty of science came in. We went from nothing, not even knowing what the virus was, to discovering the virus, developing drugs, and then having a phenomenal response. The epidemic went from a few gay men to now, today, 78 million people having been infected, 39 million deaths, 35 million people living with HIV, and the epidemic still rages with over 2 million new infections each year. So this is a list of the drugs that have been developed for HIV, and it's extraordinary that I went from 1981 through the middle of the 1990s taking care of people without adequate therapy. And then as the years went by, from 1987 through the mid-90s, we developed these 30 drugs, and this I consider one of the most important transformative discoveries in biological sciences. We went now from people having a life expectancy measured in months to now if somebody comes into my clinic and I put them on therapy, was recently infected, I could predict if they were about 25 years old that they would live an additional 50 years. So the life expectancy now is about 71 years. Just think of the difference from 6 months to 50 years. So as I mentioned, there's so many different kinds of science. I'm talking about the biological sciences. To us in the area of medicine, this is the equivalent to landing on the moon as far as we feel. Now, I became director of the Institute because I wanted to expand the horizons and look at global health because they became very interested in global health. I had the opportunity of meeting with a number of the presidents, and I found out that if you get political leaders interested in certain things, good things happen. So we went from Reagan to Bush when he was vice president. He visited the NIH, and I got him interested in HIV/AIDS. Some of you may know from your parents, from history, that in the beginning of the AIDS epidemic, the federal government did not pay as much attention as they should have. And in fact, Ronald Reagan was criticized for not even mentioning the word AIDS until his second term. Not so with George W. Bush, H.W. Bush, because here I am talking to him about HIV, and in fact, he came to the NIH with Barbara Bush, got very interested, as did Clinton. Here I am showing him some of the advances that were made in the pathogenesis of HIV. He came to the NIH a couple of times, as did his wife, then First Lady, currently candidate for presidency, Hillary Clinton, also very interested. George W. Bush became very interested. And with George W. Bush came a very interesting phenomenon of global health. He started a program called the President's Emergency Plan for AIDS Relief. In 1982, he sent me to sub-Saharan Africa on a fact-finding tour to determine if the drugs that we're giving here in the United States that were saving the lives of people, like I mentioned, could actually be done in Africa in a third world setting. And if it was feasible, he asked me to put together a plan that might bring drugs to these people in sub-Saharan Africa. So here I am in a small village in Uganda, a place called Tororo, where we went around and showed that actually you could get drugs to people. 7 months later, the president, upon a strong recommendation from me and my colleagues, put together and announced at the State of the Union address in January of 2003 what we're referring to now as the PEPFAR program, which was designed to prevent 7 million infections, treat 2 million people, and care for 10 million people. Today, many years later, remember we started this in 2003, now in 2014-15, there have been about 13 to 14 million people placed on antiretroviral therapy, which has resulted in saving 7.6 million lives, which would have been lost had science not discovered those drugs and had President Bush not decided to make them available to people in sub-Saharan Africa. But it doesn't end with HIV/AIDS. Infectious disease is an extraordinary discipline. It accounts for about 16% of all the deaths worldwide, which come to about 55 million deaths per year. And when I look at infectious diseases, you look at it as those that are established and those that are emerge and re-emerged. An established infectious disease is one that you can predict by its history how many people are going to get sick and how many people are going to die. Here's an example on this slide that 2 million people die of respiratory infections, 1.8 million from diarrheal diseases, and HIV, which was an emerging disease 33 years ago, is now an established disease. In addition, there are emerging and re-emerging infections. This is a map that I make purposefully non-readable to impress upon you the number of emerging diseases that have occurred over the last 30 plus years. I don't expect you to even see it because the print is so low, but let's focus on a few of them. There are newly emerging diseases, namely ones that we never heard of until all of a sudden it happened. So if you think that we've already seen all the diseases you're ever going to see, that's a big mistake. Because just like I told you, in 1981, when I was sitting on my office, there was no such a thing as HIV. Then along came HIV, which has now killed 38 million people, and it didn't even exist 40 years ago. Also, Ebola in 1976 was a brand new disease that was discovered and has recurred over and over again, and I'll get back to Ebola in a minute. It was first recognized in 1976, and there have been many outbreaks since then until the most recent one, which I'll get back to. There's re-emerging infections, and by re-emerging are ones that have been around but come back in a different form, in a different place, in a different condition. Let me show you some examples. Some of you may have read in the newspaper about this massive outbreak of chikungunya fever in the Caribbean. It's a virus that's transmitted by mosquitoes. It never was in the Western Hemisphere. It was only in Asia and Africa. And then all of a sudden, because of the transportation back and forth by planes that can get you from one place to another, anywhere in the world in less than 20 hours, chikungunya arrived in the Caribbean, the mosquitoes were there, and now you have a major outbreak of this disease in the Caribbean. Measles, I'm sure you've read about it in the newspapers over the last several months. People stop vaccinating their children, someone comes in from another country with measles, and then you have an outbreak of measles in the United States when measles was gone in the year 2000. There was no measles in the United States in 2000. Now we have outbreaks literally every couple of months because of the very ill-advised lack of vaccinating children. Ebola has come back with a vengeance this past year, and you cannot have not heard about it because it caused a great scare in this country. It started off with a child in Guinea getting infected at the end of 2013, going unnoticed until a mini outbreak occurred in Guinea in March of 2014, and over a series of several months, it exploded into an outbreak which was much, much greater than the combination of all of the old Ebola outbreaks since 1976. 26,000 people in 3 countries of Liberia, Sierra Leone, and Guinea, with 10,600 deaths. Prior to this year, the total number of deaths from Ebola in the world was only about 1,500. Just in this outbreak, it's been almost 11,000. Now, at the NIH, we approached Ebola from a purely scientific and public health standpoint. There are vaccines. We currently have, and in fact, it's in the newspapers today, a vaccine that's being tested right now. This captured the interest of our president, shown here visiting our laboratories at the NIH in December, looking at the scientist there on the right in the white coat, Nancy Sullivan, who developed the Ebola vaccine over a period of 10 years. This is what she devoted her life to. You ask her now, she never would have imagined in a million years that her vaccine would be the vaccine that might actually be putting an end to a major epidemic. So the vaccine was started in Liberia. This is just the news, Associated Press announcements of it. We also have therapeutics, a variety of drugs that are now being tested in Liberia, some very good candidates. Remember, just last year, we had no vaccine and no drugs. And now we're testing a very promising vaccine, and we're giving drugs that look like they may be promising. We can't tell until you do a good clinical trial. I want to talk a little bit for the last couple of minutes on clinical research. The NIH is one of 3 designated centers in the country that have the capability and the training to take care of Ebola patients, namely, give them intensive care under very controlled, secure isolation facilities. Now, some of you may not know that the most dangerous profession with Ebola is what? Being a doctor or a nurse, because there were 800 infections, 500 of whom died. There's never been a disease like that has devastated the medical profession as has Ebola. We had the privilege and the opportunity to take care of 2 Ebola patients, who one was transferred from Texas and one who got ill in Sierra Leone. This is our special clinical studies unit. This is one of our nurses getting ready to go into the room. This is the room that we take care of individuals in. And this is a picture, was the front page of the Washington Post when we discharged, and that's me with my arm around Nina Pham, the now very well-known nurse from Texas, who was infected from her patient but recovered. She did well, but one of the most difficult experiences I've been through occurred just last month in March, when a physician assistant who was working in Africa got infected, and we air evac'd him to our facility at NIH. And just to show you how this was 3 o'clock in the morning. That's my staff waiting in the back of the NIH hospital. This is the ambulance pulling up. This is what the patient was put in. Notice the containment, that plastic over them, and how everybody is dressed, getting ready to go on the elevator, because this person had millions, in fact, billions of viruses in the blood as we measured, and could easily have infected anybody who touched him without this protective clothing. So here I am with one of my staff getting ready to go in and start taking care of this patient who is very intensively ill. The process of getting dressed is not something like putting on a t-shirt. In fact, here I am putting on the protective equipment on the left, with the helmet allowing me to breathe air that's pumped in so that we don't have to have any danger. There I am putting my gloves finally before going into the room, and here we are taking care of the patient who was extraordinarily ill. But when you talk about gratification in science, in this case in medicine, one of the best feelings I've ever had was after literally staying up all night for about 2 weeks in a row taking care of him. He actually was discharged from the hospital, and we saw him walk out with his mother and his father going to the car to take him back home. So I want to... Thank you. It's the nurses who really need the round of applause. I want to end with this last slide, this next to last slide, to just impress upon you how exciting the field of medicine as one of the many areas of science. Not everybody will go into medicine, and they shouldn't, because there are so many other areas that are important. But for those of you who might want to, I can tell you it's an extraordinary, exciting experience, and the future of science is certainly not with me or my colleagues, but the future of science is with you. Thank you.